because he's reading from another institute, the other readings. He's doing also third readings. But if I look at the first and second readings together, this person has read over 25,000 mammograms in 10 years' time. He has seen 171 cancers, but only missed 4. Now, I wished I had all kinds of these radiologists in my screening program, because he's excellent. But that you can see over the time that the sensitivity and specificity remains very constant. He's always, in a sense, in a specificity in a constant high, between 90 and 95% and 94%. And on his sensitivity, he's even 100%, 91%. That depends on how many are you reading, because your sensitivity, if you only have in your batch of readings a few cancers and you miss one, your sensitivity goes immediately down. But sensitivity and specificity for readers, for radiology, is very important, and you can easily control that now too. Lately in the news, you read a lot about controversial issues in screening, overdiagnosis and overtreatment. Overdiagnosis is in fact a negative effect of screening. Everything, always if you do something on an intervention base, you will find cancers that will never harm the woman, because she will die of another disease before she will die of this cancer, this detected disease. You can also say that we find the cancers too early, because the woman doesn't have enough years to die of this breast cancer. But you have to also to realize that it is a pure statistical observation. You can never say, if you detect a cancer, if that cancer will be overdiagnosed or not. And if you find a cancer, you have it pathologically proven that it is a cancer, you cannot tell the woman, you have a cancer, but I don't think it is a grade 1 cancer. We don't do anything, we do a watchful waiting, and we see each other again in a half-year time. That's not an option. You will do a treatment. It may also be that our nomenclature is not good, because if we talk about a ductal carcinoma in situ, it is in fact a high potential and high risk lesion. It's not a cancer yet, but because it has cancer in the name, we treat it like a cancer. We knew already quite a long time ago. This is from the breast in 2001. This was from the Dutch program. They said, if we do a screening program and we detect 100 cancers, from those 100 cancers, 18 will still die of cancer. They will have not a benefit of the screening. 7% will be overdiagnosed. They die of another cause of breast cancer, but knowing the disease. That's an impairment of quality of life. About 48% will survive, but they would also have survived without a screening program. Because of the treatment, they probably have no metastasis, they would have survived anyway of effective treatment. The benefit may be that now the detection has been earlier, they benefit a little bit more with lumpectomy instead of a mastectomy. And 27% survive thanks to screening. That were the data from the Netherlands. If you talk about overdiagnosis, it has also a lot to do how you tell it to the women. There's a lot of framing to do. If I read the literature, it is how are you presenting this information? I read it is a major problem. It is 50% are overdiagnosed. The UK review came to when they looked at the randomized trials, because the only way to look at overdiagnosis are the randomized trials. But the randomized trials, they appeared a long time ago. The last one ended in 1990. That was also in another, they used all analog techniques. And if you want to know the overdiagnosis, you have to follow up the women until they die. And that has not happened. Most screening programs, most randomized trials, the women who were in the control group received screening afterwards. So they have not been you cannot determine exactly what is the overdiagnosis. They came to the best estimate that is about 19%. But what does it say, 19%? It says if you have a background incidence of 7 cancers per 1,000, that means that one of these, over 10 years that you die on this cancer, that only one of them is overdiagnosed. So if you would say it in other words, a woman age 50 participating in a screening for the next 20 years she has a 1% lifetime risk to be overdiagnosed and treated. On the other hand, you know also that no woman has ever died of overdiagnosis, in contrary to late detected cancers. So we can also talk about current issues are differentiation and screening policy. Should we screen the whole population in 2 years interval, or should we differentiate there? You can also say in Sweden they do screening from age 40 till 50, they do that in 18 months. And then they screen every 2 years, and in the elderly age group from 75 and higher, they do it every 3 years. With screening, you can also do a risk group identification. You can easily, after the first screening round, know exactly who are the women with high density breast, that you can separate them from, offer them more frequent screening, or offer them also an ultrasound afterwards. And it's also at what age to start and at what age to end. I learned that here your incidence of breast cancer is very high in the earlier age groups. But because also if I look at your age pyramid, there are not many women in the above 50 who can have a cancer, who can add the numbers to correct this. But probably it may be that the right age to start is 40, 45, 40. That may be discussed. It is not written in stone that it should be at the age of 50. And also with the newer techniques, the digital mammography, they have a much higher resolution, and you can even see more. And there are also newer techniques coming, like tomosynthesis, which can even, tomosynthesis, for the ones who don't know this is a regular mammography, but then during the mammography, it's not one picture what is taken, but there is about 14 taken. And so they create a 3D image of the breast. You can then in fact scan through the breast like a normal CT scan, but then you can see if there are already lesions, and the densities are better to define. You can see, the studies show that you find about 20% more cancers and your recall rate is lower. So that's a new technique which is very promising, but it has not been recognized yet for screening. I think I stop here for this moment. The point for you to take home: breast cancer can often be cured when detected early. With the implementation of organized screening programs all over the world, more and more women are diagnosed with an earlier stage of cancer. Mammography screening is a public health service to identify in a normal and asymptomatic population women with an elevated risk for breast cancer. We are looking for cancer, but at a screening, we are not diagnosing. We are just looking for there are signs in this mammogram that needs further assessment. We are not making a diagnosis at that time. The screening test is performed with a special dedicated device called the mammography. The EU screening guidelines have the objective to prevent harm by optimizing the benefit-risk ratio for population-based screening. Mammography offers still the best compromise sensibility and specificity as a screening tool. The sensibility and the specificity of a mammography depends on the quality of the test and the operator. That's why we need to have, radiologists are very important, and we have to have good quality parameters for them to test them. And no screening test has an accuracy of 100%. And that's why we have to have screening programs with a constant high quality. Thank you.
Thank you, Dr. Dewar, for your excellent and informative presentation. We'll keep the question at the end of the session.
Yep.
And now we'll call the second speaker. Thank you. We'd like to invite Dr. Abigail Suzanne Caudier. I hope I pronounced the name correctly. She Assistant Professor, Department of the Surgical Oncology, University of Texas. From November 25 to November 27, she was clinical instructor. She had general surgery residency program from University of North Carolina, Doctor of Medicine, University of North Carolina. And she had master in the clinical research design and statistical analysis. She has had a lot of experience in the Society of the Surgical Oncology, American Society of Clinical Oncologists, and American Association of the Cancer Research. Dr. Abigail, most welcome, please.
Okay. Thank you so much for the opportunity to come and visit Saudi Arabia and meet everyone. This has been a great experience in the little time I've been here already. So we've covered a lot of the issues that I'm going to talk about today in the great talks we've had already this morning. So I'm going to touch on those things again and hopefully give a little bit of a different perspective. When I started coming up with this talk, I decided to brainstorm what were the controversies in breast cancer screening, and all of a sudden my list became pages and pages long. There were just so many issues to talk about. So we're just going to touch on them today. The first thing you have to think about is what is screening, and certainly we've heard lots of definitions this morning. In 1951, the U.S. Commission on Chronic Disease said the presumptive identification of unrecognized disease or defect by the applications of tests, examinations, or other procedures which can be applied directly. That's a very vague, legalese kind of definition. I like the World Health Organization's definition a lot better. I think this is a lot more practical. There are several questions they said. Is it a health problem? I think we'd all agree that breast cancer is. Is there treatment available? Are there facilities in place? Is it detectable preclinically, and is there a suitable screening test? Is that test acceptable to people? And do we know the natural history, i.e., can we prevent this from progressing by intervening early? And are the costs acceptable? I think when we talk about the goals of screening, we need to detect a disease that causes significant harm. We have to detect a disease in the asymptomatic phase, when intervention can really change the natural history of the disease. We have to find a test that does more benefit than harm, and have it available and accessible to those at risk, and have a treatment that's effective and acceptable to people. It does no good to diagnose someone with something when they're not going to accept treatment for it. I think everyone in this room agrees that breast cancer is a significant risk to the health of women. And these are U.S. numbers, but there are about 40,000 deaths from breast cancer in 2012. And when we look at the way that is going, from 1975 to 1990, the death rate was going up every year. In 1990, all of a sudden, we've seen a reversal of that, and the death rates have actually been going down by about 2.2% annually. And we think that partly that's due to screening, so early detection, but also improved treatment. And when we look in Saudi Arabia, we see that certainly it's a very big problem. It's the second most common breast cancer in the world. But in Saudi Arabia, it's the most common malignancy in women. It accounts for 20% of all female cancers, and the second leading cause of cancer death behind lung. But more importantly, I think the incidence is increasing, and this is from the Saudi Cancer Registry. That incidence had gone from 10% in 2000 to 24% in 2005. So when we think about screening, we have a couple of questions. First, who should be screened? We have to identify who's at risk, identify if different groups should be screened differently, and then decide if intervention benefits all patients. Second, we have to decide what tests we're going to use, and then how should that be implemented. Once again, these are U.S. numbers. When we look at the prevalence of breast cancer, or the incidence of breast cancer by age stratification, certainly we see that as women get older, their risk of breast cancer goes up. So when we decide who to screen, we have to decide where is that cutoff that the incidence is high enough to go through screening. In 2009, the U.S. Preventive Services Task Force in America concluded that there was no benefit to screening women less than age 40. They looked at different age stratifications and found the number of women who had to be invited to screen to extend one's life, and found that you had to invite almost 2,000 women to be screened to save one life in ages 40 to 50. And that number went down to 377 if the age was 60 to 70. They then estimated that 3.5 out of 1,000 women in her 40s will die of breast cancer in the next 10 years without screening, and that with screening that only goes to 3. So basically what they were saying is young women, if they get breast cancer, we can't affect the outcome by screening. I think a lot of us will disagree with that. Certainly we know that young women have tumors that grow with a faster growth rate. And when we look at tumor sojourn times, which we had a very eloquent description of in the last talk, we certainly see that. In women aged 40 to 50, we know that that's 2.4 years. So this is the amount of time that the tumor could have been detected mammographically before it becomes clinically evident. And that span gets longer as women get older. But I think this is more telling, is that 40% of the years of life lost to breast cancer are actually among women diagnosed in their 40s. So this is an area where we have a huge potential to prolong life. Now, I think this is especially true in Saudi Arabia because patients get their cancer at a much earlier stage. We know in Saudi Arabia, 2/3 of the breast cancer patients are premenopausal. That's very different than in the US and in Europe. The median of age of diagnosis is 46, which is 10 years younger than European women. That's a huge difference, I think. And the majority of the patients are young. 38% of breast cancers are diagnosed in women aged 30 to 44. That's a very young age. And this is data that I took from a paper I found, and when you look at the distribution by age, really the majority of breast cancer in Saudi Arabia is in patients aged 30 to 44 or 45 to 59. I think it's actually very interesting when you look at those bottom two lines. Age 15 to 29, which I can tell you would be a very low incidence of cancer in the US, is very similar to the age over 75 years old, where you would see a much bigger difference in that in other countries. So when we decide who we're going to screen, we then have to decide what test we're going to use. And we say that screening tests should be judged on 3 things, and these have all been touched on this morning. One is the validity. How well is that test able to distinguish between those who have disease and don't have disease? The second is efficacy. Do we believe the result that it gives us? And then third is reliability, and that is the ability of the test to produce reproducible results. When we talk about validity, we're talking about sensitivity, or the probability that a person with disease is going to be detected with that test, and specificity, probability that a person without disease is classified that way by the test. And certainly we've talked about this morning, but detecting more positives usually leads to more false positives. But if we say, okay, we want a really specific test, then we decrease our sensitivity. There's lots of problems with a bad test. What happens with a false positive? You get unnecessary testing and any complications that may come with that. An inaccurate label may cause anxiety. But on the other side, a false negative leaves disease untreated. So we really have to ride this balance, thinking about the prevalence of disease, the severity, how good the test is, and how acceptable the test is. When you look at US women and they polled them and said, how many false positives would you accept for one breast cancer death avoided? 2/3 of women said they would accept 500 false positives across the population for every breast cancer death avoided. And about 1/3 said they would tolerate 10,000 false positives. That's a huge number. However, when you ask women who've actually had a false positive, 40% of them describe that time as very scary or the scariest time of their life. But interestingly, almost all said they were glad they had the test. I think there's another risk of false positives. There's one study looking at attendance and biannual screening after a false positive recall. So women who came back, right? So after a negative mammogram, most people continued with their regular screening. If they got recalled once, the attendance went down to 65%, and dropped repeatedly the more times they got called back for something that turned out it wasn't cancer. I think people quit believing in the test. They now have had this very scary time, they've had added procedures, and they still had no cancer, so they quit believing in the test. The other thing we need to talk about is efficacy, as we said, and that's related to the positive predictive value and the negative predictive value, meaning if I have a positive result, do I believe it? And that goes up as the prevalence goes up. Oh, sorry. And this has to do with age as well. So this was a breast cancer surveillance consortium, and they looked at women undergoing biopsy and how many actually had in situ invasive or invasive disease. In young women, that rate was 28%, but the test became much more reliable as women got older because the prevalence of disease went up. And then one other subject that we've talked about is just the reliability of the test, and that relates to the first and second reads that we just heard about. So let's just briefly talk about the kinds of tests that we can do. There are a lot of radiologists in this room that know a lot more about this than the surgeon on the stage. So I'll just briefly go through that. Certainly screening mammography is our gold standard. fairly sensitive and specific, but obviously the sensitivity is decreased in dense breasts. In the US, this has become a real issue, and you can see this, "Are you dense?" It's one of the campaigns going on in several states, including my state of Texas. If a woman has a mammogram with dense breasts, they get a letter saying, "You have dense breasts, and mammogram may not have detected your cancer. Discuss this with your physician to see if MRI is appropriate." There's also screening ultrasound. There have been a lot of people interested in this because there's no compression or radiation. It's relatively cheap. The sensitivity is not affected by density. However, it is very operator dependent. It requires a large amount of time, and it has a very low specificity. In the largest prospective multi-center US trial looking at ultrasound as a screening tool, they diagnosed 40 patients with cancer out of 2,600 patients. Only 12 of those were detected by ultrasound alone. When they look at cancer detection rates, mammogram alone diagnosed 7.6 per 1,000 women. Mammogram and ultrasound was a little bit better, at 11.8 per 1,000 women. And then an add-on to that study, they looked at MRI, and certainly that picked up even more cancers. But remember, it's not just sensitivity, it's also the positive predictive value, because as we go up on the sensitivity, then we start diagnosing some false positives. And when they looked at positive predictive value of mammogram alone, it was 22.6%. So patients who had an abnormal mammogram who truly had a cancer. Ultrasound alone was pretty miserable, 8.9%. Mammogram and ultrasound was 11%. And then adding mammogram, ultrasound, and MRI, very expensive endeavor, the positive predictive value became 19%. Screening MRI, at least in the US, has had a lot of interest. It's highly sensitive. It's better than mammography in high-risk populations, and especially those with dense breasts. But there are a lot of false positives. It's not as sensitive as mammogram in some lesions, and it's very hard to implement. It's expensive, invasive, and time-consuming. And there's never been a benefit on breast cancer mortality. As we see it from the surgical standpoint, we often have a conversation with a patient. We say, "You're a breast conservation candidate." For some reason, an MRI gets ordered. And when we do, there's always all of these little false positives to the point that women just say, "I just want a mastectomy." So you have to be very careful about ordering this test, because even if you don't have a true positive result, the anxiety caused by it can alter a patient's decision. So lastly, should we screen? Well, there's lives, money, and emotion on the line. We have to balance the benefit compared to the harm of false positives, this issue of overdiagnosis. So when we look at this, we turn to the experts, but there are some limitations in looking at prospective studies. Screening is a hard thing to study in a prospective manner. There's detection bias, meaning finding disease that would have never caused harm, and this is the overdiagnosis controversy. There's lead time bias, right? A patient is diagnosed by screening it at the age of 50, whereas she would have been diagnosed by clinical exam at the age of 55. If she was going to die at the age of 60, regardless of how the cancer was identified, it makes it look like mammogram had a benefit, which maybe it really did not. There's also the length time bias in that mammogram picks up those slow-growing cancers that actually have a better survival. So the American Cancer Society recommends yearly mammograms starting at the age of 40. They recommend clinical breast exam and breast self-exam. But then we start looking at these other groups that have tried to take the data that we have and come up with data-based recommendations. In 2009, the U.S. Preventive Services Task Force came up with a very controversial recommendation. They recommended biannual mammograms from the age of 50 to 74. They said there was no benefit to screening patients less than the age of 50, no evidence of benefit for patients greater than 74, and they said that biannual screening should be the way we go forward instead of annual screening. This caused a huge public reaction in the U.S. You'll see these quotes that were in the paper and the national news. A Harvard professor, 10,000 lives are being saved by mammography. These idiots want to do away with it. It's crazy, unethical, really. These are very emotional words to put out there. Even the American Cancer Society said that these findings could turn back the clock on the war on breast cancer. This all caused such an uproar that our government actually passed an act requiring insurance companies to provide free preventive services for women, including breast, ovarian, and lung cancer. And you can see this is another one of the taglines. Mammography saved lives. One of them could be yours. It was all a very emotional reaction. Certainly there's been a lot of debate recently about the Canadian National Breast Screening Study. This was a prospective trial, randomized women aged 40 to 59 to mammogram versus observation. So just looking at the trial design, all patients got a physical exam at the baseline. They were then randomized to mammogram versus observation. Now it was an open list randomization, meaning there were lines on a piece of paper, and you wrote you were supposed to go one to the next, to the next, to the next. And there's been some question of was that really the way people were randomized. But they basically got 5 annual screens. So really the treatment part of this trial was 5 years. Then the patients were followed for 25 years. When you look at the screening period, so those 5 years that they were randomized, there were 666 cancers in the mammogram group versus 524 in the control group. Interestingly, there were more breast cancer deaths in the mammogram group than in the control group, and we'll talk about that in just a second. Then they followed those women for 25 years, and over that whole 25-year period, the number of invasive cancers was 3,250 in the mammogram group versus 3,133 in the control group. And the breast cancer deaths were very similar. When they looked at the hazard ratio for breast cancer mortality in the mammogram group, they found it was 0.99, so they really said there was no difference. But then in it, they said after 15 years, there was an excess of 106 cancers in the mammogram group. So they were basically saying, or the way they interpreted this was that 22% of cancers are due to overdiagnosis. Now, I don't know about you, but this question of overdiagnosis is a little bit unsettling for me. As a breast cancer surgeon, it's unsettling for me for people to tell me that 20 to 30% of the breast cancers I'm treating, I really didn't need to treat. And I would invite them to some of my clinics to tell me which 20 to 30% of patients I should just send home and say, you have breast cancer, but we don't need to treat it. Certainly there's some that are obvious, but there are a lot that aren't to me. And so I'd love for some of these experts to come help guide me on a day-to-day basis if they really think we're overdiagnosing that much cancer. Interestingly to me in this study, in the mammogram arm, they said 73% were screen detected, so they were found during those mammography. But then they said 68% of those breast cancers were palpable, which seems quite a large number to me when you talk about screen detected. When only 27% were interval cancers, meaning found between the screening intervals. Certainly palpable tumors were larger than those found by mammogram. That's not surprising to any of us. I think this is interesting too. The 25-year survival for cancers diagnosed during that 5-year screening period was significantly better in the patients in the mammogram arm. So they concluded that annual mammogram in women's age 40 to 59 does not reduce mortality, that 22% of screen-detected breast cancers overdiagnosed, and that there's one overdiagnosed breast cancer for every 424 women screened. A couple problems with that study. First of all, it was a historical cohort. These patients were followed for 25 years. The treatment period was actually in the 80s. I think we would all agree that our screening techniques and our treatment have improved dramatically since the 1980s. I alluded to this earlier. Patients underwent a clinical breast exam before they were randomized. And so they were assigned to groups using an open list. Mammogram group in that initial period tended to have more advanced cancers, and more women assigned to the mammogram arm died within the first 5 years. Certainly you can imagine if you were screening someone, you did a breast exam, you felt a palpable mass, you might be tempted to put them in the mammogram arm versus the control arm. The other thing is that women volunteered for this trial. So it may have biased them to women who either had a palpable finding or who were at high risk. And I think that is actually shown in their data. When you look at the hazard ratio for breast cancer specific mortality, the prevalent cancers, that means a cancer diagnosed when the patient enrolled off that first screening or that first physical exam, was 1.47 compared to incident cancers, cancers that were diagnosed after that initial visit. So I think that helps us know that women came in because they were concerned about something. We discussed this earlier today. The UK consensus panel recommended screening every 3 years for women aged 50 to 70. And then there was the Cochrane analysis. So this looked at 8 randomized trials comparing mammogram screening to no screening. They said screening is likely to reduce breast cancer mortality. Once again, this overdiagnosis issue. And they say for every 2,000 women screened through 10 years, only 1 will have a life prolonged, 10 will be treated unnecessarily. And they concluded that it wasn't clear whether screening does more harm or good. So where they all agree, though, is that breast cancer screening does reduce mortality. And when you look at these are some of the major trials, the overall risk reduction is at relative risk is 0.8, so a relative risk reduction of about 20%. Where they debate is where the harms are, the overdiagnosis, overtreatment harm. So what do the people want? Because remember, the last line of all of those screening things was, is the test acceptable to people, to the population you're screening? When you look at, certainly, Americans, 500 US adults, 87% the screening was almost always a good thing. And most indicated that they would overrule a doctor who recommended against screening, and I see this in my clinic all the time. Now, part of it is that the population as a whole doesn't necessarily understand the harms of screening. In one survey, US women, only 7% believe that there could possibly be breast cancers that grow so slowly that their health wouldn't be affected by treatment. Only 8% thought that a mammogram could harm a woman that did not have breast cancer. And they actually predicted the false positive rate for 10 years of screening at 20%. So obviously the overall population very much underestimates this issue. Now the medical community, though, pretty much agrees with women. When they looked at a web-based survey of primary MDs after that 2009 recommendation came out from the US Preventive Task Force, a vast majority still recommended annual screening versus biannual screening. And most of them still recommended screening starting at the age of 40. So we sort of have it in our minds how we're going to do it, not really going to change it no matter what the data says. So inclusions, screening should be offered to those at risk. And certainly I think in America I favor screening starting at the age of 40, but certainly in Saudi Arabia where your breast cancer happens so much younger, I think there's a really good reason for starting screening early. We have to recognize the limitations of the tests. Mammogram is sufficient in most patients. MRI is good for high-risk patients. And there is a benefit to screening. There's probably a reduction in mortality of 20%. The cost of false positives, it seems to be acceptable to the population that's tested. Now, we may be over-treating some people, but I don't think we're smart enough right now to know which ones they are. And we know that women and physicians want the test. So I just want to thank you. This is a picture of our medical complex. The big pink palace is what we call it. So anyway, thank you.
Thank you so much, Dr. Suzanne, for this nice lecture. I think for me, I agree that Saudi breast screening should be at earlier age. Thank you so much. Now we'll go for the last lecture in this session by Dr. Salha Bouyasoum. She will provide us a lecture about breast cancer screening and Hamad Medical Corporation experience, State of Qatar. Dr. Salha, she is a senior consultant, hematologist and oncologist. She is the program director for fellowship training hematology and oncology, and she is the director of Hamad Medical Center breast cancer screening.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My task will talk about breast cancer screening in Hamad Medical Corporation. It will represent only our hospital experience. It's not our national screening. So my talk will started with introduction, then about breast cancer control, breast cancer epidemiology, followed by breast cancer screening standard risk, and we also started breast cancer screening for high-risk populations, and we'll end by conclusions. So the breast cancer is the most common cancer in Qatar as the other countries. The incidence rate increased from 45 per 100,000 in 2003 to 2007 to 56 per 100,000 in year 2008 to 2011. Qatari patients accounted for 32% of all diagnosed breast cancer in women. The prevalent age, as other Arab countries and similar to Saudi Arabia, was in the range between 40 to 50 years old. So 36% of all affected women. So as everybody knows that the four principal approach for cancer control, including breast cancer, is the prevention, early detection, diagnosis, treatment, and palliative care. So I might focus on early detections. As know that the state of Qatar has been dramatically increased in their populations. For example, in 2007 was around 700,000, but in 2008 it actually reached up to 1,500,000. And in the most recent published population statistics, it reached up to in 2010 to 700,000, and then current last populations up to 2 million. The total population pyramids is almost similar to Saudi Arabia, but we have more male population in the young age group because of expatriates and for labor for infrastructure. So as you can see that the most common cancer in Qatar is the breast cancer. It reached up to 38% in women. And male side is the colorectal cancer and lung cancer, the most common. Based on our cancer registry data in 2007-2011, also showed that breast cancer is the most common cancer. It's around 36.3%. And this is just to show the rate. And as we can see here, similar to Saudi Arabia cancer registry, that the age distribution is that the median age at diagnosis fall between 45 to 59. And as I said, like more than 30% is below younger, and in young population below the age of 45. This is another illustration that the median age of the diagnosis fall between 40 to 45. So our breast cancer screening in Hamad Medical Corporation established in April 2008 as a self-referral center or through the referral from primary health center. We have that screening program as single program. Started with the screening office for call and recall, and we have a basic screening unit is located in Hamad General Hospital, and then we have assessment center which is in the same area, Hamad General Hospital, where patient receive a triple assessment. Seen by breast surgeons and do clinical exams, then further study regarding mammography or MRI and biopsy. Then the cases will be discussed in our multidisciplinary for diagnosis and treatment plan. And our multidisciplinary will establish, we have our own diagnostic radiologist, pathologist, medical oncology, radiation oncology, and histopathology. Once the diagnosis of breast cancer is confirmed, then we refer to the treatment group, which is the, for initial treatment, either, surgery or systemic treatment later on with the radiotherapy. This is our pathway for screening. Usually we have breast awareness program. We have extensive over the whole year, breast awareness. We have outreach program located in our cancer hospital, but also in collaboration with Supreme Council of Health. And we have also also awareness of program for primary health center. So the patient will be referred, usually the eligible group will be between 40 years old to 69. This is in our hospital, but we have also set the policy for national screening. Our program will start the age of 45 to 69. So the program participants, they will have initial physical exams by our clinic, seen by our physician, and then they will do mammography with supplemented ultrasound if needed. And then in the same day. If there is abnormal result, then we'll call for assessment clinic by our breast surgeon, and then they will make biopsy or further MRI test, and then the result of the test will be discussed in our MDT. And if the test double assessment is benign, then we'll go back to the program standard program screening. This is our data. Number of invited women from 2008 to up to date in 2013. Total number of women screened gradually increased from the start in April 2008 to 2013, so a total of almost 4,000. And almost 1/3 of the participant was Qatari, and the 2/3 of the participant is non-Qatari. This is distribution for all women screened by nationality. As I said, the Qatari Arab was 1/3, and Qatari other Arabs is almost another 1/3, and then the last one is the other population. As you can see, like in the diagram, that started with almost 450-500 cases, and then stabilized in 2012, 2013, around 700. So the age of women participate in the screening is the majority of women in the age 40 to 49. Less attended by women age of 50, 59, and also 60, 69. Some women, they are insistent to do standard screening, although they are below the age of 40, but almost because of they have family history, we accept them to do the screening, but in the initial stage of screening, by just doing ultrasound. But later on, the 2012, 2013, we referred them to high-risk clinic. This is the radiological investigation for women who attend in the screening. The majority of patients have only basic screening, but also almost like half of them, they have supplemented ultrasound. Because we have a patient, we have women, they have, because of their younger age group, they have dense breast. So most of our radiologists, they are not comfortable reporting it just only as pass it as normal without supplemented ultrasound. And in some cases also we requested MRI. This is our histological investigation. Initially, when we started the program in 2008, we get to use the FNA more than biopsy, but then when we get sometimes an inadequate result or not enough cells for evaluation. So we moved from depending on FNA to do core biopsy. And this is also when you'll go to our sensitivity, specificity for the programs, actually it's improved when we do biopsy. This is one of these quality indicators that we monitor our program with. A positive predictive value, it's noticeably that it's improved over the last 2 years. Also, our sensitivity is improved. Since we started in 2008 was 51, and then in 2012 70%. But I just want to make sure that to mention that it is not single reader specific sensitivity. It's collectively for all our radiologists. Specificity also is improved over time and reach up to 83% in 2012. This is our invasive breast cancer detection rate per 1,000 screened women aged between 40 and 70 from period of 2008 to 2013. And you can see that in the first year we examined 465 patients, but there is no detection of cancer. But later on, in the other years, we found like our invasive detection rate is higher than other countries, most of the time because we are offering screening mammography for free and open in the afternoon, and also it is kind of one-stop clinic. Patient comes to the clinics and you'll have mammography in the same day. So majority of those patients already they are symptomatic. Not asymptomatic. When we ask them if they are having any symptoms, they will say, no, we don't have, and they want to include it in the program. But when they come to the clinic, they have already breast lump or sign of symptoms of breast cancer. So we can see that in our detection rate for invasive breast cancer is, in the initial days, it was higher than benchmark. And this is in situ breast cancer detection per 1,000 screened women. And it's, as I said, there is like increase in the initial days, but then it will be like, within the benchmark around 3. As I said, the majority of women, more than half, have invasive breast cancer, and 44% was non-invasive cancer. And regarding cancer detection rate by age group, the majority of women who have cancer detections more in the age group around 60 to 70 years old. It's reached up to 24.7. And probably because of dense breast, as I said. As a medical oncologist, we've seen a lot of women in young age group. Sometimes it's reach about unusual. When I trained in Canada, I've seen patients like elderly patients around above 50. But in our population, we've seen a lot of patients who's young. It's reached 29 years old, 25 with breast cancer. So that's why we started our high-risk screening clinic. And also to want to make sure that, because of our breast cancer incidence, usually in young age group. So we want to identify if those patients related to high risk inherited gene mutation or not. So we established our clinics in March 2013 as multidisciplinary clinic, and it is first clinic in, as I said, in Qatar, dedicated exclusively to provide genetic counseling and high-risk management women risk of familial breast cancer ovarian syndrome. So in this clinic, we provide genetic counseling and testing as appropriate, offer multidisciplinary service, as I said, and also to reduce incidence and morbidity mortality of cancer in those high-risk group, and also to establish our breast cancer high-risk database. So since we started the clinic, we've seen 253. Usually those patients was referred from our multidisciplinary meeting, or referred from other specialty or from primary health center. And we do risk assessment, and we'll check for them if they are eligible for high-risk screening or not. So the 185 out of 253 was considered to be high risk, and we offer 76 of patient genetic tests. Usually genetic test is not available in our center, so we send them abroad. So 29 out of 76 patients, they have gene mutation, and 26 were negative. BRCA2 positive was 3 only, and 10 patients, they have 10 for variant. This is the pathway for high-risk clinic. As I said, we women with high-risk breast cancer would have family history. We risk stratify them. If they consider high risk, then we'll see them, we'll do the testing, and then if they discover they are high risk or they carrying gene mutation, then we'll do like 2 group A or B, and then we'll discuss them in our high risk MDT discussion, and then we're recommending the plan. If they are negative, then we'll shift them to standard risk screening. This is just an illustration of our population that was seen in our clinic. So the majority of patients who tested and get positive results, the BRCA1 positive in 8 patients, and the 3 patients they have, and actually in 18 patients, BRCA2 positive was 3. This is correlation between the patient who have BRCA gene positive and also symptomatic patient who diagnosed with breast cancer in the same year. So if you calculate, the breast cancer BRCA positive incidence was 6. This is in Qatari populations, and breast cancer incidence of this year for Qatari population was 60. So the proportion, it will be like 10% of symptomatic patients have BRCA gene mutation. In non-Qatari, actually, because the test is costly, so it's not covered by government, so this test is not reliable. As conclusion for high-risk screening, the incidence of breast cancer cases of BRCA1, BRCA gene mutation among Qatari patients reach up to 10%. 40% among women seen in the clinic considered to be at high risk for carrying gene mutation, and they did genetic testing. 38% were BRCA1, BRCA2 positive for heterozygous mutations. The majority of patients was in BRCA1 gene. 82.1% of cases of BRCA1 mutation or variant for non-significant were affected and diagnosed with breast cancer. And they all affected, the most detected mutation, BRCA1 gene in exon 10, we found it in 3 families. The second frequent mutation, BRCA1, was detected in exon 16 in 2 families, and third one in exon 16 and 8 in 1 families, and 1 family had familial mutation, BRCA1 and detected in exon 5. This study actually done with our group in collaboration with Calgary University in Qatar, and we want to expand, our, what the women think about breast cancer practices in Arab population living in the state of Qatar. This is a cross-sectional study. Involved 1,000 women who have, it is 87.5% in Arabic-speaking women, age 35 years of age and older. I think this slide is not so clear, but most of the patients, the woman who's attended the practice, attended breast cancer screening practice, they have maybe 96% of them, they want to do it for own health. They are concerned about their health, they want to be healthy. That's why they are involved in practice of breast examinations and screening practice. But the other things that the second most common, they promote them to have breast screening is the doctor. The doctor, they advise them in the clinics, they have to go for screening. And the opposite, and the other things, pressure from family, or they want to be practiced. But the other graph, actually, for women who's not attending breast screening, what is their reasons? One of them that the doctor, they didn't tell them to practice. And then the other one is embarrassment and fear from getting cancer. So this is a summary of the result. In addition to low level of awareness and low participation rate in breast cancer screening practice, 1/4 of the participants state that the doctor talked to them about breast cancer, and less than half of the women interviewed believe breast cancer can be prevented. Women who engage in breast cancer practices were more likely to have doctor who talked to them about breast cancer. And they believe more in good, excellent health, that the cancer can be prevented. Wanted to know if they have cancer and felt their health needs more being met, and the main reason given for not planning breast cancer screening were lack of doctor recommendation, fear, and embarrassment. So in conclusions, we conclude that the incidence of BRCA mutation does exist in our society, in our population, and probably contribute to high incidence of breast cancer in young age group. So it's epidemiological and transitional research in this field is highly recommended. We need to have also joint effort among Arab countries to develop our own database. And effort should be made for improved methods of prevention, early detection through population-based screening program, and increased public awareness. We have our experience from our hospital, but now for Qatar we have a national cancer screening program, and they are under implementation. We put the policy and regulations, and we have tender for different companies to start our screening program in national level. And from initial, the policymaker, they decide to start screening, started from age of 45. And then there will be the frequency every 2 to 3 years. And additional recommendation I thought is we need to provide accurate data, our own data, not the international, but also we incorporate international medicine-based evidence to guide us, to guide policymaker and women to take a correct decision in regard to standard breast cancer screening. And thank you for listening.
Please, if you have any questions, Dr. Ibrahim.
Yes, Thank you very much for these interesting presentations. I have a comment and a question. The comment is regarding doing mammography for Saudi women before the age of 40. This has been raised many times in different meetings and gathering. I am not in favor of that. All the literature that shows mammography is useful is for women who are 40 years or above. All the literature. It is true that we have younger age incidence in Saudi Arabia, but because of the density and the anxiety and the false positive issues, I don't think there is really strong evidence that we can start mammography before the age of 40 unless we want to do a pilot study. But we cannot really recommend it. The question I have for Dr. Christopher is about what is the latest on the European recommendations for annual clinical exam and breast self-exam recommendations in Europe. Thank
you. Oh, so now it's on. There is no European recommendation to do breast self-examination or clinical examination. Breast self-examination is not being recommended as a tool to detect breast cancer early, but it is being used as an awareness tool that you still use it because many cancers are also, interval cancers are mostly detected by the women herself. So lumps are being able to be detected, but that are clinical symptoms. With breast cancer screening, we try to find non-symptomatic breast cancers. So the clinical examination and the non-symptomatic breast cancers, they don't relate to each other. So it's not an official recommendation.
Dr. Saleh Uthman.
Thank you very much for this wonderful speech. And I really learned a lot of these lectures. And regarding of the screening in Saudi Arabia, just I know also from this wonderful speech that only 3 or 5 out of 1,000 will be picked up the lesion, and but I didn't know out of these 3 or 5 or out of 1,000 how many they are in situ, how many they are stage 1, and I don't know how much patients. The women receive of radiations if they started by age of 40 or 45 when they reach by 80. So if they do it by, every 2 years, so we are exposing the woman 15 times or 20 times. The other one, really, Dr. DeWolf is very important and new for me that it is only 20 patients will be survived with thanks from the screening. And also Dr. Sozins mentioned that it is out of, I think, 1,000 or 10,000 screen over 10 years, only one, if I'm correct. You mentioned in one of the slides. So I'm repeating all these things just to correct me, because I think, to start screening in Saudi Arabia without evidence, best practice, guidelines, we are harming our women more than, really we are helping the women. So the screening being started a couple of years now, here or over there, but there is really no study has been done about what have been done with these screens. Are we doing investigations? Are we investigating the patient or screening the patients? Because from the reports, we see most of the patients, they come with advance. No in situ. It is only one person. So it means over 3 years, we are not doing screening. We are really doing just investigation. We are investigating our patients. So I think this should be reviewed before we take over. Thank you. Comments, please.
Yes.
Not evidence, for our country.
In your country, yes. Yeah. True, there's not, there are no trials in this country yet to truly assess that. Can everybody hear me? Is this picking up? Okay. So we are extrapolating data from American, Canadian, and European cohorts. And that's why I looked at some of the data, especially related to age, and that younger, breast cancers in Saudi Arabia tend to be in younger women. They tend to be HER2 positive. I didn't present that data, but there is some data looking at Saudi Arabian women versus Swiss women. They're more likely to be high grade, HER2 positive, thus more aggressive. And so I actually think that it makes sense to screen women, and especially starting at an earlier age. I actually think in Saudi Arabia, you may stop the screening process at an earlier age, where we're saying in the US, stop at 75, but goodness, they still do them at mammograms at 85 and 90. I get patients coming in with a mammogram that I say, why did they order this? It may be that in Saudi Arabia, you need to stop the screening or at least have a longer interval at an earlier age. But I think that as so many young women with breast cancer, I think it's a real opportunity to save some lives here. But you're right, there's no data in Saudi Arabia to do that, and maybe that's what comes out of this conference, is this collective decision to study this in a prospective manner.
I'd like to make some comments too, because if you start a screening program, you cannot expect results in 5 years. You have to have a certain time that the results can develop. That's why also now the Canadian study comes after 25 years. Canadian study was the randomized trial study, but also there are other countries, like in the Netherlands, they started in 1990. They have published this year also a report after 25 years of screening. 25 years of screening, they say, in the Netherlands, they save annually 775 women lives a year, women a year. And each life that has been prevented of death, that person lives about an average 16 and a half years longer. It's not just a life, they live 16 and a half years longer on average. And you have to screen 1,200 women to prevent one person dying of breast cancer. These are also data that are more difficult to find because they are in fact good news. Like what you read often in the newspapers nowadays is market journalism. They want to have a number of readers they want to publicize their readers, so bad news is good news. If you read something about a Canadian study, which was already been discussed for 25 years, that the randomization was not good, it comes out and it creates, again, a mass media information what polarizes even more the controversies in screening. But the good news you hardly hear. The UK trial, they in fact overrules the Cochrane collaboration from Herr Götze, because Herr Götze said 7 of the 8 randomized trials did not comply to his quality measures. The UK trial said they're all valid, and they have still come back to the 20% mortality reduction. Mr. Götze says himself 15%, but it is 20% on the randomized trials. In the Netherlands, they achieve more than 34% mortality reduction on 25 years of screening. Each woman that participated in the screening, if she has participated, she reduced her risk of dying of breast cancer with about 50%. Then you come to the point, from where do you start screening and where do you stop screening? It depends very much on the way how your age pyramid has been built up. If I look at the data here in Saudi Arabia, I see that a large proportion of your population here is very young. It's not like if you look in Europe where the population is in reversed pyramid almost. Like a woman in Switzerland, when she's 70 years old, she still has a life expectancy of 19 years. So that makes sense to still screen till 75. There are still more and more tendency to screen younger women. In the United Kingdom, they have also reduced their age from 50 to 74. And now they start in Austria with a screening program, including ultrasound, and they start also at the age of 45. So there is a tendency to lower the age. But when I give a recommendation on a screening program, I say, okay, start screening at the age of 50. And make sure you have a good coverage. And if you have, because it is much more easier to do a screening program in an elderly population than in a younger population, also for the radiologist. And if you have the screening program established, you start to extend it to the lower ages, because then you have also the quality what is required to do a good screening program in the younger population.
You know, I attended several meetings with, I think it was one in Pan-Arab conference, cancer conference. And always we are kind of debating whether to start screening or not to start screening among, like, you know, Arab populations or among Gulf area, and we're still debating. I mean, this is the time to start, at least, you know, if it is not a standard risk screen, national screening, at least we can start multi-nationality, multi-center cancer screening trial to see our population and see what is benefiting them. We can decide about what age group, frequency, how much the aggressiveness of our breast cancer, how we can prevent it, and implement a strategy how to go ahead with a screening program. Because I'm an oncologist, you know, I've seen in our clinics very aggressive behavior of breast cancer. Usually ERBR negative, HER2 positive. Sometimes the tumor size, like, you know, less than 1 centimeter, 8 millimeter, but it's still very aggressive. And sometimes even they have a grade 3 lymphovascular invasions. So it's totally different biological behavior than the Western countries. I think this is the time to decide when to start and you know, make a policymaker to start the screening. Probably a debate about when and how frequency. We can start as a multi-center trial and then go ahead for other. Then to decide about further treatment, further standards.
It's outdated, but when we implementing in our countries, we have to understand what's going on, and we have to do it correctly or not to do it. There is one simple thing: we are jumping to screening, but we're jumping, awareness and teaching our ladies. Most of the ladies in our countries, they don't know basics how to examine. They don't know how the importance of everything, in their life for the screening of the breast cancers. So I'm really worried about screening, because everywhere now, NGOs, hospitals, everyone is starting doing screening. Some people are starting from 35, some people are starting from 50s. So it shouldn't be really done. When we're doing something, we should do it either correct or not do it. Yeah. That's it. Thank you.
But the thing is, it should go hand by hand. You start awareness and at the same time set the policy to start standard screening. If we wait until, people be matured, but if you do awareness and this campaign without having screening, so people will say, what is your standard screening? How can I do I heard about it, I know, I'm very interested to go for screening. But if you don't have the infrastructure for screening, how people they can progress? It's not enough just breast awareness to early detection for signs and symptoms without having backup standard screening in place.
Perhaps I can add a little to that. I agree there's a need for local data, and data across the board may not be easily translatable. And in a way, when we started our breast screen in Singapore, that's what we did. We did a pilot project and looked at, collected some local data. And I think in terms of screening, things can, I quite agree with our colleague from Qatar. Basically, things can change along the way. When we first started screening, we screened women from 50 to 69, but now we've opened up the screening to women above the age of 70. So I think at some point it's not an all or none program. You may have to do it in stages, and you can modify your screening program as you gather more data. Thank you.
I think there's a major point here to make. A screening program is a public health intervention. It should have a political decision. In the United States, they have not a screening program. There's a lot of individual screening. There's a recommendation. Awareness is also recommending screening, but it is not a screening program. A screening program is systematically inviting all women in a certain age group to come for screening. There is also no difference between public or private practice. It is because there is no competition between the screening. A screening is a service that is offered by your government, your country.
Thank you, Dr. Wolf, about overdiagnosis. And it's sequelae, still now one of the obstacles for this breast screening now. How to avoid this and manage this overdiagnosis from your European experience?
Yeah. As I said, overdiagnosis is a statistical observation. We don't know which women are overdiagnosed or not. We know that certain cancers detected, like if you have DCIS detected in a 70-year-old woman, that might be overdiagnosis because she doesn't have the time anymore to die of this cancer. Overdiagnosis might be less of a problem if you start earlier on screening, because if in the younger population you have a longer time that the cancer can be developed till a lethal case, so that you know that it is not overdiagnosis. Overdiagnosis has also a lot to do with the terminology. Because if you say that in DCIS, a ductal carcinoma in situ, is a cancer, then you talk about overdiagnosis. If you say that DCIS is a high potential risk, is a high risk lesion, and you treat it differently, then it's not a cancer. It's the same what you do with cervical cancer screening. A SIN3 is in fact the same as a DCIS. It's also a cancer in situ. But the SIN3, you do a conization, and you don't call it a cancer. And then it is, you lower your incidence rate. So it has a lot to do with perception about how you frame it. But in principle, with any early detection test, you have overdiagnosis, and you have to cope with it, because that is inherent on the system.
And I would say also this, in that in all of these things, they talk about screening leading to overdiagnosis, and that implies that all palpable tumors are not overtreated, right? Who's to say that a 1 or 2 centimeter tumor, the difference between screen detected and palpable, makes one an overtreatment versus one another? I don't think we know who we're overtreating. There are certain people that we know are obvious, right? The 4 millimeter DCIS in an 80-year-old woman, I absolutely guarantee that is an overtreatment when I operate on her, if I do. But I don't know in a 40-year-old. What if it's a low-grade DCIS? Am I really overtreating it, or could this in a year have been an invasive cancer? We've all seen small cancers that metastasize to the lymph nodes very early, so I agree. The overdiagnosis, I think, is called by people who aren't necessarily taking care of patients on a day-to-day basis and really saying, who am I overtreating?
So Suzanne, about in our area, in Hassa area, we start screening at the age of 40 years now. But still, the most cases coming before this age of 40. Yeah, the most our cases now above 35 like this. We all recommend you start screening at this 35 years old, particularly in our Hassa area, because this is the area of high incidence of cancer, breast, and Saudi Arabia. We all recommend you to start this screening at the age of 35, or not recommended to start?
I don't think there are really recommendations to start before the age of 40, because the issues with breast density and things lead to so many false positives. And when we talk about where to start screening, we have to look at the harm, the false positives and the anxiety versus the people we're benefiting. And a lot of that has to do with the aging breast, and when the breast density becomes to a point that there's a reasonable positive predictive value and specificity and sensitivity. So although radiologists may be better inclined to answer that, that's just the surgeon's perspective.
I agree completely with you. I think basically there's no recommendation for screening below the age of 40 unless there's a family history. And the main reason really is the breast density. For some high-risk patients in the younger age group, we may screen with MRI. Some people look at ultrasound, but ultrasound, I think you end up with a lot more false positive. In fact, there are whole breast ultrasound machines, but we don't practice that because we don't feel that there's enough evidence there.
We've noticed in our screening program, although this is a small program, that a lot of women, they want to do like a screening in the young age group below the age of 40 because they have family history. That's why we started our high-risk screening clinic. So now in our breast MDT, any patient who has diagnosed with breast cancer below age of 40, we refer them to high-risk screening clinics. So we do like genetic tests, we counsel them, and then we'll proceed with testing. And if they are positive, then we'll advise to do risk reduction strategies. Part of it, prophylactic mastectomies or oophorectomies, and also to screen their family. So this is a way of, you'll understand better our populations, why they are getting breast cancer in young age group, and also to offer them some kind of screening programs that it will not include it in the standard risk.
I am a woman who is a strong believer in screening. We started education in the Eastern Province 10 years ago, but after some years, the ladies will ask you, okay, you educated me, so where should I go? So education by itself, I think it cannot work. If you want to start these campaigns, you have to provide the ladies with something. You have to provide them with the screening. So you cannot just tell them what to do without provide them with the mammography. I do believe in mammogram, and mammogram not only a matter of reducing mortality, it also improves the quality of life, because if you diagnose them early, the quality of life of the ladies and the families will be much better. So I am a woman who is also pushing for mammography. I am aware of the controversies around the guidelines, but there is a question I want to ask for the people who is against the screening. So what should we do if there is no mammography? Thank you.
To the whole panel?
Yeah. So I think your question is what to do if mammography is not available? Yeah, good question. Right.
Yeah.
Right. If when I talked about the criteria, we talked about a screening test. Is it accessible? Is it available? And if it's not, then I think you have to rely on education and breast self-exam and clinical self-exam. But certainly, I think screening should be a goal, but it takes a lot of resources to put that in place.
Yeah. Also, a point you made about you believe in mammography. Many women who participate in screening, 95%, they have a reassurance that they don't have cancer. Of course, a few of them still have an interval cancer, but many women are very happy after the mammography that they receive a negative result, a positive result for the women, of course, but that they didn't see anything on the mammogram and that it is negative, and they feel it as a reassurance.
Any more questions, please?
Excuse me.
Okay, go ahead.
Thank
Dr.
you.
Haidar.
I am Dr. Haidar Nasri from Ministry of Health. We have already implemented this program in Riyadh. We can say we start as a pilot, but really when we implement it, we face a lot of obstacles and difficulties. And when we review references and the experience of other countries, we don't see any full pictures of this program. We feel that a lot of things is missing, even in other countries who implement this program. Like مثلا because if we don't implement this program in a high quality, we will make a problem. Okay, and the cost of effectiveness of this program will be very less, or we lose it. Some of these problems that there is about performance indicators is not clear. We don't know exactly the percentage of every indicators. How should it be recall, like the duration of giving results to the woman. What is the duration? The duration when you make the recall, when the woman coming and receive other procedures, what is the duration? The duration of making this case is confirmed, and the duration of received treatment, like this. I don't see any example of these indicators, performance indicators. And also for quality assurance, we don't know a full program for quality assurance for this, for screening, to depend on it. And if there is difficulties, where it is, like as a record, if the percentage is less, what is the reason? Or maybe because of the reading of images, it is not high quality of reading images, that the recall is high. So we don't know exactly the reason. Even for something like software, there is no comprehensive software for screening program. And a lot of data, we miss it. After 2 years, we don't have a comprehensive software, really. And if we want to make a study, a lot of information missing, like recording high risk, recording a lot of things. So where we can find this information? And what example, ideal example of implementing this program among countries, we can depend on it. Thank you.
That question is not difficult to answer, because I mentioned about European guidelines on quality assurance and mammography screening. In this document, there are 39 parameters being taken. There are waiting times being specified. There's recall rates to be specified in the incidence round and the prevalent round. For instance, we say that a woman should, between her mammography and her result letter, should not be more than 8 working days. In the screening program I'm responsible, I have an average waiting time of 3 days. If a woman receives a positive result, what is then the follow-up? Like, I have heard that if women receive a positive result, that the woman has to take contact with the doctor to make an appointment. We ask our doctors to take an appointment with the woman because they are informed a few days before, so that the woman doesn't have this anxiety when she reads this letter that her mammogram is positive, but that she receives a phone call from her doctor saying, I've received information you have a positive mammogram, please come to my clinic and we make the assessment. So these recommendations are all in the European guidelines. They are downloadable from the internet. I can give you the link where you can download all this information on waiting times and on quality parameters for the professionals.
Can I just comment on this?
Sorry, but another.
Because the time for this already exists now. So we don't want to be late for the next session, please. So it's the time now for the lunch, please. Thank you so much.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد عليه أفضل الصلاة والسلام وعلى أهله وصحبه أجمعين. We are starting the third session now, and we will start by Dr. Fatma Ibrahim Saoud Al-Hanai. About her, she is working in Ministry of Health, Department of Family and Community Health, and responsible for maternal health in the Dakhliya region. She has the degree of Bachelor of Science, Sultan Qaboos University, the degree of Doctorate of Medicine, Sultan Qaboos University, Certificate of Registration, Oman Medical Specialty Board, MRCS, Royal College of Surgeons of Edinburgh, Master degree in International Public Health and Sexual and Reproductive Health. She is a master trainer in the screening for breast cancer for healthcare providers, master trainer in integrated management of child health illness. Can you start?
Thank you. Good afternoon, everybody. I am Dr. Fatma Al-Hinai from Department of Family and Community Health, Ministry of Health in Sultanate of Oman. First of all, I would like to thank the organizers and especially Dr. Omar who gave this opportunity to speak about the experience of screening program in Sultanate Oman. The contents of the presentation will be demographic features of Oman, cancer among Omani females, screening program for breast cancer, challenges and future direction. First of all, I would like just to say a brief introduction about Oman, which is located in southeastern corner of Arabian Peninsula, and it has a diverse geographical features. Administratively, it is divided into 11 governorates. With a total population of approximately 3 million, 73% of the population living in urban areas. Male per 100 females is 103. Adult literacy rate is 86. Ministry of Health expenditures as a percentage of government and expenditures is 4.5. All the health services in Oman are free of charge, and it is easy accessible with most of the health facilities are within 5 kilometers from the households. Is there a need to start a screening program? The Oman National Cancer Registry showed that Oman has an emerging cancer problem, with the breast cancer is the most common cancer affecting females and represents 24.8% of the cancers affecting Omani women. This is followed by the thyroid cancer and non-Hodgkin's lymphoma. It is most common between the ages 49 to 59, and it peaks at the age of 55 to 59 years. If we trace the trend of breast cancer, we can see that breast cancer cases increased over the past years. And this is due to the change in the lifestyle, a change in the demography of the population, i.e. increasing the number of elderlies, and partly because of this awareness about the breast cancer, which increased the number for early detection. And this number is expected to rise due again to the changes expected in the demography of the population, changes in the lifestyles, and Ministry of Health for this gave a great deal of thought to start a screening program to provide a treatment for early diagnosed cases, and also to provide a palliative care for advanced cases. Although there was no screening program before 2009, breast examination was part of the systemic examination given to the ladies attending the reproductive health services. There were also health education materials were available to increase awareness of breast cancer. After providing a comprehensive maternal care, the Department of Family and Community Health put strategies to provide health services for women in the post-reproductive period, and these strategies were included in the 7th five-year plan, 2006 to 2010. Are we ready to start the screening program? For this, SWOT analysis was conducted in 2008 and showed that yes, it is possible to have a screening program because we have a large net of primary healthcare facilities which offers women care. There is an available mammography services, radiologists and general surgeons, and also oncology center. It is also, there is an outreach teams to provide knowledge and the service, as well as community support group who can help in increasing the awareness for breast cancer. However, the analysis showed that starting a national-based mammography screening is not feasible due to the limited number of trained radiographers and lack of national quality control mammography machines, as well as some of the available mammogram was outdated and needs upgrading. The only threat that was detected is whether this screening program is going to be accepted by the community or not. Establishment of the program was done in 2 phases. We started first by conducting a pilot study and was started in February 2009. And this was done to test the screening system and fine-tuning it. It was started in 2 governorates, and the target group was 40 to 49 years. I know this is a small group of women, but this was chosen to have a better control on the collected data and the screening process. Recruitment of the clients to the screening clinics was through a self-referral and internal referral from other clinics in the health facilities. Screening modalities that were used, it's a combination of clinical breast examination, breast self-examination, and mammogram. Mammogram was a reserve screening tool for those who have a high risk for breast cancer. And the service providers were trained nurses and doctors on CBE and BSE who were trained by experts from these governorates. And the management of the cases is as per the guideline of management of breast cancer, and these guidelines again developed by experts from the 2 governorates. Awareness campaign was going hand by hand with the screening process, screening for breast cancer, and it was at the level of community and female schools. In 2009, during the screening program, the awareness campaigns involved 221 schools with a total of 10,156 students. Female teachers were 1,991, mothers involved in these awareness campaigns, 1,374. Evaluation of the pilot project was through a continuous field visit by a team from the Department of Family and Community Health to the project, and also through the management of the monthly reports from these governorates who used the special designed forms for requested indicators. It was also, the evaluation of the pilot projects was also done by WHO Regional Advisor Dr. Ibtihal and the UNFPA consultant, and their evaluation was they used for the evaluation a disc review and field visits to the pilot projects. The main findings that were, the main challenge that were found in the pilot projects was all related to mammography services. So to address these challenges, the DFCH recommended establishment of committee for improvement of mammography services. Phase 2, where we prepare for the expansion of the service. By the end of 2009, Prof. Miner, who is a UNFPA consultant, trained a group of national and master trainers for clinical breast examination and breast self-examination. For this, training curriculums for training of trainers to be used by the national trainers to develop a master trainers, and also a training curriculum for a training of healthcare providers to be used by the master trainers. Counseling training curriculum was also developed. Expansion of the program. Based on the experiences learned from the pilot project, it was the expansion of the program was included in the 8th five-year plan, 2011 and 2015. And it started with inclusion of 2 more governorates in 2011. Management guideline on breast cancer at secondary level was developed by experts from secondary and tertiary level.
7 minutes.
Health education campaigns with participation of non-governmental organizations. development of training modules for community support group to help them in their campaign, in their community education sessions. And these are some of the produced bilingual leaflets. So the main goal of the program was to improve women's health by reducing mortality from breast cancer. The objectives were to raise awareness of women on breast cancer and early detection, early diagnosis and management of breast cancer, reduce the morbidity and mortality due to breast cancer in women. The program composed of 5 components: service provision at all levels, primary, secondary, and tertiary, and the age group was expanded to include 40 to 59 years. Health education using also at all levels at health facilities, community, and female secondary school. Counseling is done by trained healthcare providers using a counseling curriculum and counseling card developed for that for screening for breast cancer, developed specially for breast cancer cases. Referral system from primary to secondary healthcare according to the national protocol, management and follow-up of the screened cases, and also for those with detected abnormality, detected breast lesions, and those who have normal findings. As I mentioned, 3 modalities for breast cancer were used: CBE, BSE, and reserved mammogram for high-risk cases and those with positive findings in clinical breast examination. Criteria for high-risk: menarche before age 11, first child born in early 40s, family history of breast cancer in young below 50 first-degree relatives, previous benign breast disease with atypical hyperplasia. And initially, BMI more than 35 was also included as a high risk, but this was removed due to the service is not yet well developed to accommodate all the referred cases, as we find that 80% of the referred cases for mammogram were with BMI more than 35. Management information system: specially designed registers to record information of screened and rescreened women at different levels of health care, primary, secondary. Also, there is a monthly and periodic reports from the governorates started the screening program, and field visits by the DFCH team to monitor and evaluate the screening program. Beside the service provided by the Ministry of Health, we have also the non-governmental organization, which is the first patient National Association of Cancer Awareness, which is the first patient advocacy group founded in 2004 by 3-time survivor of breast cancer, Ms. Yuthra Rawahi. The responsibility for this association is not only to increase the awareness, but also to support those diagnosed with breast cancer and in need for comfort and information. In 2009, the association launched the first mobile mammography unit, and their work in the community is in coordination with the directorates of health services in the governorates, and also in coordination with the local breast cancer associations in each governorate. And this is some of the results of pilot study. The percentage of women screened with CBE of target group reached up to 85% in one governorate, while in the other governorate is only 41%. And this could be explained because of the geographical location of Dhahira governorate, which is at the border with the United Arab Emirates, and so families living in UAE for working, they do the examination there. Women attending breast clinical, either by self-referral or internal referral, it's obvious that the self-referral is almost 50%, indicating that the attitude, reflecting the attitude of women towards the screening program. Percentage of cases with confirmed breast lesions It is found that 97% are benign tumors. Early stage breast cancer represent 2% of the cases, and locally advanced breast cancer, stage 3, is only 0.7%. But this also low percentage in the cancer cases can be also explained either by, it can be also explained that the early, the awareness of the woman about breast cancer makes them bypass the directly self-referral to the surgical clinic, and so not passing through the screening clinic. The challenges, there are many. Rescreening is one of the challenges by CBE or mammogram. Also, the availability of digital mammogram, availability of specialized radiologists on mammogram, and availability of female surgeons. Future direction is to have a national-based mammography screening, expansion of the program to include all the governorates, continuation of health education campaigns at all levels, establishment of extended screening center where the woman will have the triple assessment, clinical, radiological, and histopathological. More and more collaboration with NGOs to increase public awareness, and also help to, and also in helping to provide the service through the mobile units they have. This is the end of it. Thank you.
Thank you, Dr. Fatma, for your valuable lecture. And now,
with the second speaker, Dr. Ahmed Saleh Al-Shamlan. This is the director of Al-Amal Specialized Oncology Center, clinical oncologist in the National Oncology Center, general secretary of the National Cancer Foundation. He is graduated from Sana'a University and training for radiology department in Pakistan, membership in Radiology Pakistan, fellowship radiology therapy in Pakistan. Think about this is breast cancer screening in Yemen. About the experience, Dr. Ahmed.
Thank you very much for your presentation. And in the beginning, Bismillah ar-Rahman ar-Rahim, Assalamu alaikum. I want to thank the organizing committee, especially Dr. Omar Bayamin, to give me this chance to speak about this in front of you about our experience in breast cancer control. And actually here I will speak about not only on breast cancer, screening for breast cancer, but about our difficulties and our experience, how we deal with breast cancer and what we face. Actually, we have a breast cancer screening program, and it is not that national, but we started in the capital of Sana'a with this our center. Okay. Sorry. This Yemen, you know, Yemen is in the south of Saudi Arabia, with about 23 million people, and we with about 550,000 square kilometers. In Yemen, the breast cancer is the first common breast cancer in all the cancers cancers in Yemen, and it occupies about 13% of all, or 12 to 13% of all breast cancer in all cancers, about 23% of female cancers. Breast cancer is diagnosed actually in Yemen in younger patients with about a mean age of 46 years old. Unfortunately, most of our cases, they come in advanced, locally advanced and metastatic breast cancer, and most of them under poverty line. Life Center, which is Al-Amal or Al-Hayah, Markaz Al-Hayah, Life Center is the first breast cancer who is specialized in screening and dealing with breast cancer for screening and for detection, for education. In LCBC center, we do health education, clinical examination, training for self-examination, mammography, and biopsy for specific cases. Life Center belongs to the National Cancer Control Foundation, which is a non-governmental organization. In health education and awareness, we do our activities toward the general public, the general people, education and training for breast self-examination. We concentrate on all females, especially the educated people, and we try to reach to the uneducated people. We go to the secondary schools, university schools. We do our programs in the TV, in the radio, in the newspapers, and through our brochures and our materials to educate people about this. Actually, I want to rise or to handwrite. There is a problem in our patients or our people. We are concentrating on the people for education for young females, how to raise their awareness about breast cancer, and we advise them to come to our centers to do screening and to do their examination and to be trained to be self-examination. We are concentrating on the young people to be educated about this and to reflect their information to their families. When we go to all the governorates or most of the governorates to do like these activations and lectures for women to advise them to do and to go to the centers, breast centers, to do their examination and to be trained for breast self-examination as part of our breast cancer control. Also, we train our visitors. Especially, we are concentrating on the medical staff. We are training them to be our our staff, or to be our helper to train other people how to do their self-examination and to educate other people for their activities. Medical staffs, I think they have to take their roles in the early detection of breast cancer. Sometimes in our screening programs, we are concentrating in the general people. I think other medical staffs, they have to take their roles in the screening and in the cancer control programs to educate other people and to do early detection for the cancers. These are our units in the Life Center. Scientific meetings, we do scientific meetings with the doctors other than radiologists, surgeons and other specialties. We do mammogram. We have 3 mammograms. Now we have 3 mammograms, 3 digital mammograms, and now we have 2 stereotactic mammograms. We do ultrasound examination for all our visitors, young people, and the people who are more or older than 45, we do for them mammogram. After clinical examination for everyone who is visiting our center, we take complete history and registration about their symptoms, or if they have any about history, family history, complete history, and clinical examination and ultrasound for all people. Then, if there is, if the patient or the visitor is older than 45, we do for the mammogram, and we do biopsy, trocat biopsy. We are doing actually for any risky or suspicious mass. We do meetings for radiologists, from different governorates to educate them as clinical or training with the expert how to diagnose breast cancers through the ultrasound, through mammogram. Also, actually, we have a defect in the number of the radiologists who are expert in radiology or breast imaging radiology. I want here to speak about the other specialties which are dealing with the other patients. We are facing the other doctors like surgeons or gynecologists. They are not, they are not contact, or we have and they have misunderstanding about how to deal with the breast cancer. Breast cancer or breast mass. We find there are many surgeons or different surgeons who are directly, if they find a breast mass, they do directly lumpectomy without biopsy. And we know if we do lumpectomy and it claims cancer, our line of management it will be completely different. We try to meet with the other specialties like surgeons to know what are the proper lines and how we deal with the breast mass from the beginning and how to be referred properly. Also, we concentrate in the other staffs to do their complete clinical examination. A complete clinical examination, for example, for any doctor, any patient come to him, as part of his clinical examination, he has to do breast examination to find if there is, and from the history, if there is any abnormal mass to be detected as early as possible. We have another branches from our center in the other governorates, like this in other governorate, which is in Eb governorate, and because of the distant areas in our governorates, we try now to open other branches and other centers in the governorates. These our visitors in one center, as one example of our center, and we found after our education of people, we find many people who are younger than 25 and younger than 35, they come for examination. And okay, we see in the diagram from people for less than 35 years old, they come more than 50% of our visitors are come to do examination and to do training by themselves. These most of these visitors to our center come by themselves, and about 10% only as referred people to our center to be examined. We cover in this center the people from different governorates or from our all Yemen. This is this diagram showed us our diagnosis in the center about with Bayrad result, and about 3.7 diagnosed already after biopsy with Bayrad 6, Bayrad 5 and 4 who need biopsy. Some people in Yemen, we advise them to do biopsy. They are still afraid. They don't agree. Some of them are go abroad, or some of them are go without treatment and go home. And this is one of our problem, which sometimes we ask, and when we discuss with the surgeon or some doctors, they still have the same idea. Biopsy, it will cause metastasis to the disease, and this is one of our problem, and which we need to be concentrated for in our medical or our scientific meetings with the other medical staffs. In Yemen, we have other stakeholders in breast screening. National Oncology Center, which is the governorate only oncology center in Yemen, which is in Sana'a. I am working in that center. And we have a very big now breast clinic and breast screening program in it. And also another NGOs now started to be to share with us in breast cancer and cancer control programs. In OC we have radiologists, we have breast early detection since 2012 with ultrasound and stereotactic mammogram. There is another organization now started to educate medical staffs. This Yemeni organization for education and training, they started their programs for gynecologists, short training courses or meetings for in cancer control and concentrating in the breast cancer. We found the gynecologists, they have limited idea about how to deal and how to refer breast people who I mean, in the beginning they don't make breast examination as part of their clinic. After that, they don't have idea about how to manage such patients from the